Welcome. In this lecture, we'll be discussing the different types of vertigo. Some terminology that you may hear on both inpatient and outpatient rotations is the term dizziness, which is typically used by patients and can mean a multitude of things. In the case of this lecture, it can mean vertigo, but it can also describe either lightheadedness or unsteadiness. So let's go into more detail about exactly what vertigo is. Vertigo is a sensation of spinning or movement either of yourself or your surroundings when there is no actual motion. This is an illusion of movement caused by lesions affecting any part of the vestibular pathway, such as the labyrinth, the vestibular nuclei or nerve, as well as the cerebellum. Briefly, the pathway starts with some sort of head movement, which is detected by tiny sensors in your inner ear called the semicircular canals and the otolith organs. These sensors send signals through the vestibular nerve to your brainstem. From there, the signals can either go to your eyes to help keep your vision steady, your spinal cord to help with posture, or even your cerebellum in your brain to help understand where you are in space. Vertigo happens when the inner ear sends incorrect balance signals to the brain, making you feel like you're spinning even when you're not. Vertigo can be subdivided into two categories, either peripheral vertigo or central vertigo. Peripheral vertigo, the problem is in the inner ear or cranial nerve 8, aka the vestibular nerve. These are the parts responsible for sensing head movement and balance. Peripheral vertigo is much more common than central vertigo, and where the issue is with the brain itself, especially the areas that process balance signals from the inner ear, such as the brainstem or even the cerebellum. Now we can use the different ways that these pathologies present, as well as a physical exam finding that we typically see in people with vertigo. We use nystagmus to help differentiate this. Nystagmus is an involuntary repetitive movement of the eyes. Here, I've included the different types of nystagmus that you may see. Horizontal, in which the eyes rapidly move right or left. Vertical, in which the eyes rapidly move up or down. And of course, rotational, where in real clinical practice, it may look like they're vibrating, but they are actually rotating in a circular pattern. The way that these present, as well as the onset of presentation, can be used to delineate between peripheral and central causes. So nystagmus presentation in peripheral is typically going to be described as delayed in onset and fatigable. When a positional change triggers vertigo, there's a short lag before the brain registers the abnormal signal from the inner ear. This causes the nystagmus to appear a few seconds late after the movement, aka it's delayed in onset. Thus, with fatigability, with repetitive movements or tests, the response weakens or even stops because the brain starts adapting to the abnormal input. Thus, with too many or too much repetitive motions, the nystagmus will fatigue. Typically, the nystagmus that we see in peripheral causes will be horizontal, and there should be no postural instability. This is, of course, compared to the presentation of nystagmus and is a central cause, in which the onset is typically immediate. This is typically constant or non-fatigable. Typically, central vertigo can present with nystagmus in any direction, but be on the lookout for vertical on test day, and of course, postural instability, as sometimes the brainstem or even the cerebellum can be affected, where we do not see that affected in peripheral causes. Also, with the presentation of central vertigo, you may also see new focal neurologic deficits, and of course, skewing of the eyes, aka the eyes are misaligned. Simply put, these two presentations are polar opposites of one another. Thus, if you know one, then you should understand the other. There is another physical exam move that we can use, such as the head thrust test. In this test, the examiner turns the patient's head rapidly towards what is believed to be the affected side. It is positive if the patient is unable to maintain visual fixation. Here's a diagram illustrating this. We take a patient, we ask them to look midline. We turn their head rapidly one way. If they are able to keep their eyes midline, or at that set point, that is a negative test. But as we can see here on the bottom, we ask the individual to look midline, we rapidly turn their head the other way, and it looks like they are not able to keep their eyes on that middle, or on that object that they were looking at. This would describe a positive head thrust test. This suggests a peripheral cause of vertigo. Be aware of that for test day. Now, for the rest of this lecture, we will primarily be discussing the peripheral causes of vertigo, but there are some central causes which should be discussed in other lectures. Please be aware for a test day that the big takeaway is to understand how peripheral and central nystagmus presents. Let's begin talking about the peripheral causes with benign paroxysmal positional vertigo. Now, normally, with the inner ear, you have sensory hair cells which detects the endolymph movement with head or body motion. This causes the brain to perceive motion or position. We already briefly talked about the inner ear having the semicircular canals as well as the otolith organs. But with BPPV, what happens is you have some sort of calcium debris depositing within the semicircular canal, seen here. This leads to improper motion of the endolymph. Endolymph is fluid which exists within this inner ear. This results in a spinning sensation. So, in better terms, we have tiny calcium crystals referred to as otoconia. These are typically located in the utricle. In BPPV, these crystals become dislodged and actually can move into these semicircular canals. When you change head position, the crystals move in the canal, which move the fluid, aka the endolymph. This sends false signals to the brain that tells you that you're spinning. It is high yield to understand that typically this occurs in the posterior semicircular canal. This occurs because of the way that the utricle and the posterior semicircular canal lie. It's much easier for the otolith to float into this posterior semicircular canal. And BPPV is the most common cause of vertigo in general. BPPV has a very unique presentation. This is typically seen in older females, and you have your peripheral vertical findings, all your nystagmus findings, that is associated with certain types of head movements. Typically, this lasts less than 1 minute. As the crystal settles down, once you stop those movements, the signals will stop, thus it will resolve quickly, and the symptoms are typically reproducible. If you move your head in that same position, you'll get the same exact presentation. A mnemonic to help remind yourself of BPPV is BPPV itself. These are going to be brief episodes, typically less than 1 minute. Positional, just like the name implies, typically affects the posterior canal and it causes vertigo. So be on the lookout for an older female who gets vertigo-like symptoms with certain head movements on test day. Now, this is diagnosed typically clinically with certain types of maneuvers. The most high-yield maneuver to know is something known as the Dix-Hallpike maneuver. This leads to the vertigo and the nystagmus when the affected ear is downwardly turned. What we do is we take an individual and we turn their head either right or left, and we rapidly lower them to the ground or to the table. If they have nystagmus and vertigo-like symptoms, this suggests an otolith in the posterior semicircular canal. Another test that can be utilized in order to diagnose is something known as the supine log roll, or even known as the head roll test. This is exactly what it sounds like. You have a patient lie flat on their back, and you either ask them, or you can do it yourself, turn their head to the right, and then turn their head to the left. If they become having symptoms of vertigo and or nystagmus, this suggests a horizontal semicircular canal. Dix-Hallpike is used to diagnose, not to treat. That is high yield to understand, as well as knowing what is looking for in what canal. Supine is for horizontal, Dix-Hallpike is for the posterior. Now, the way that we treat BPV is with another maneuver. Typically, the Epley maneuver is more commonly tested, but sometimes it is also tested the Semont Plus maneuver. Here, A, here, and B, here. A is the Epley maneuver, Semont is B. The Epley maneuver is simply just a series of the head and body movements used to treat BPPV. This moves the displaced crystals from the semicircular canal back to the utricle. You don't have to know exactly the stepwise patterns for either of these. Just know that they both exist and they both are used to treat BPPV. The rest of the treatment is typically conservative. Usually, medications such as meclizine are not indicated. The reason why they're not indicated for BPPV is because this will only treat the symptoms. It will not correct the underlying problems. This will be your answer on test day. Now, another type of peripheral pathology will be something known as Meniere's syndrome. Meniere's syndrome is caused of too much fluid, aka endolymph, building up in the inner ear. This leads to excessive inner ear fluid pressure that messes with balance and hearing signals. The symptoms are typically a unique triad. of hearing loss, typically sensorineural, tinnitus or ringing of the ears or ear fullness, and of course your peripheral vertigo. Note that the episodes of peripheral vertigo are longer in Meniere's, typically greater than 20 minutes, than in BPPV, where they're less than 1 minute. A mnemonic to help remind you of this is heft of fluid in the ear, where the fluid portion reminds you what the pathology is. Heft stands for hearing loss, ear fullness, falling, aka vertigo, and tinnitus. As we can see, this is the classic triad. Meniere's is diagnosed clinically with this unique presentation, and it is typically treated with lifestyle modifications, such as limiting salt, caffeine, alcohol, and nicotine use. In individuals who do not utilize these drugs or medications, other meds can help, such as diuretics, which can decrease the volume, or even meclizine. Remember, meclizine is not indicated for BPPV, but it can be used in Meniere syndrome. Even sometimes steroids are used. But for the purpose of test day, most likely they want you to understand that lifestyle medications are the first treatment option. A way to remember this is dash your salt. Remember, D is for diuretics, A is to avoid alcohol, salt, caffeine, S is to stop smoking, and then H is for hydration. Meniere syndrome is typically compared to something known as cerebropontine syndrome. Now, this has a multitude of different presentations. Here, this usually is caused by an acoustic neuroma, which affects Schwann cells, aka it is also known as a schwannoma. This compresses both cranial nerve 7 and 8. Remember, cerebropontine syndrome is caused by a multitude of different things, such as vascular causes, as well as other tumors. Here's a diagram describing one such cause. This itself is not an acoustic neuroma, but it does well to describe what's going on. As we can see, here's the cerebellum, and here's the pons, and we see this mass here. And next to this mass, here, where these arrows are, is cranial nerve 7 and 8. As this area, or as this lesion is damaged or gets larger, it can actually affect cranial nerve 7 and cranial nerve 8. Thus, this will present with vertigo, hearing loss, and tinnitus, which is the exact same presentation as Meniere syndrome. But also be on the lookout for cranial nerve 7 being affected, such as facial palsy, or aka Bell's palsy sometimes, and imbalance or ataxia, as it affects the cerebellum too. A big difference between this and Meniere syndrome is that this is gradual in onset. Typically, one symptom will start, and then the next one will start, and then the next one will start. Compared to Meniere syndrome, you'll get that triad right away. So be on the lookout for that on test day. This is typically diagnosed via MRI, and the treatment is dependent on the causes and other factors. More so, you want to know how you diagnose this and how to differentiate this from Meniere syndrome with the symptoms. Now, the next one that we'll talk about is labyrinthitis versus vestibular neuritis. In vestibular neuritis, you have an inflammation of the vestibular nerve. The symptoms here are typically going to be after some sort of upper respiratory infection. Whether it's viral or bacterial, you'll have some sort of upper or URI. This will lead to an acute onset peripheral vertigo associated with nausea and vomiting. Typically, vestibular neuritis is diagnosed clinically, and the treatment is going to be steroids because it is an itis or an inflammation. Labyrinthitis or inflammation of the labyrinth or of the inner ear is going to have the exact same presentation. The only difference in this is that labyrinthitis has hearing loss. In labyrinthitis, this causes both vertigo and hearing loss because it affects the entire inner ear, the entire labyrinth, including the cochlea, which controls hearing. In contrast, vestibular neuritis only involves the vestibular nerve, which controls balance. So it causes vertigo without hearing loss. So the key difference is that labyrinthitis impacts both hearing and balance, while vestibular neuritis affects balance only. This is also going to be diagnosed clinically, as well as going to be treated with steroids. What I'm trying to get at in this slide here is that these are actually the exact same thing. They only differentiate in where the inflammation is taking place, the vestibular nerve and the labyrinth, and the one symptom presentation. No hearing loss in vestibular neuritis, and complete hearing loss in labyrinthitis because it affects the entire cochlea. Because it is an inflammation, it is an itis, it should be treated with steroids. The last symptom that we would talk about is something known as Ramsay-Hunt syndrome. This is due to reactivation of an already dormant varicella zoster, which affects cranial nerve 7, cranial nerve 8. Following some sort of primary infection with VZV, the virus remains dormant in the dorsal root ganglia, the autonomic ganglia, as well as the cranial nerve ganglia. These symptoms will present with facial nerve palsy from cranial nerve 7, hearing loss from cranial nerve 8, vertigo, and of course a painful vesicular rash, typically around the ocular or around the ear structures. You can see these vessels just like you would see in herpes. This is diagnosed clinically, and because it is a reactivation of this varicella, it is going to be treated with acyclovir and or steroids. Here is a table for completeness sake comparing each of the peripheral abnormalities seen or talked about in this lecture. And that concludes this lecture on peripheral versus central vertigo.